Okay,
Uh-oh.
that's all right. That means people can hear us now. So we have to be nice. So which we would be nice anyway. But,
We would be nice anyway.
yes. Okay,
Yeah.
so now I can see, Lamessa, I can see your screen perfectly. So that's good. You may want to try to like move it forward just to make sure you got that part down. And there we go. So it's moving. So we're good to go there. Now I am going to grab it back and make myself the presenter. So I'll show my screen and then we'll, okay, in theory. Okay. There we go. Now can you see my screen?
Mm-hmm.
Yes, I
Okay.
can.
Okay, that worked. That worked as planned. Okay, now we just got to have some people rolling in here.
All righty.
Yeah, I'm not sure the RHC community has pharmacy integrated as much as it needs to be. That is the
And that's the
I was
nature
just
of
gonna
the webinar.
Yeah.
yeah, that's the reason for the webinar, to get them educated on how to do it. So
Yes.
yeah.
Let's see here.
How is I know the proposed changes for 2025. How does that for CCM and remote monitoring? Is that something that's good for you guys?
Yes, definitely. The extension of, RPM is good. And even if they, include us in the regular coding, that'd be great as well. So
Yeah.
everything is moving forward positively.
Yeah, that's what I was thinking. I mean, that GO 511 code, try to use it for everything. That was sort of like fitting a square peg into a round hole. It just didn't really
Right.
work.
Yeah.
So I think that it makes a lot of sense to do it, to have it where basically, I mean, they have you don't, if you're roughly, you say, oh, wait, we got $72 before, but if you break out all the components, you're probably going to make just as much or more money by doing it. So it just makes more sense.
Yeah, I agree. I agree wholeheartedly.
Mm-hmm. So,
And any consistency you can have with billing, G codes are different, right? We don't bill G codes normally. We bill, 9 codes. And so bringing everything under those traditional umbrellas rather than pulling them out separately as G codes, I think will help it'll help streamline that whole process.
yeah, I think so. I think, yeah, anytime you can use an E&M code versus a HCPCS code,
yeah,
and you have some consistency throughout, your coding and billing, it makes life so much simpler and
yes,
so much more logical. So,
yes.
but billing has never been simple and logical.
There hasn't.
Yeah, keep us on our toes.
A new word, simple. But now, Stacey, where are you located?
I'm in Oregon.
In Oregon. Oh, okay. Oregon's beautiful. It's
It is, yes. We're having a heat wave, which is a little unusual for us right now. So it's gonna be like 90 today, and then rain tomorrow, which is typical Oregon weather. So
yeah, it's like I think it's like 96 degrees here in Tennessee. It's just like we don't have fall anymore. It's it just goes from 96 down to 40, and you just don't have that beautiful 70-degree weather like we used to.
yes.
Right. And we have overcast here in Southern California.
Okay.
Yeah.
I thought it never rains in Southern California.
Well, I said it overcast.
Overcast. Okay, not raining. Okay.
I didn't say rain.
Okay. All right. We got 2 more minutes and then we will get started. We got a few people that are rolling in. We will make this stuff available. We'll put it on our YouTube channel and we'll put it through the RHC group as well so that people can watch it after we get it recorded. So we'll make sure to share it with everybody.
Okay.
I think we had 81, 82 people signed up for it, but hopefully they'll all roll in here in a little bit.
Yeah.
I see some familiar names there in the group. So yeah.
And Mark, just Levance mentioned, so who generally is going to be attending this? And we can ask that question when everybody gets here, but just, I got the impression like office managers, maybe business side of things, and less clinicians, correct?
Yeah, absolutely. Less clinical. This is the RHC information group is mainly for administrative folks with rural health clinics. So we get a lot of billing questions, a lot of reimbursement, cost reporting, that sort of thing from the people there. There's about 5,400 members in the group. So, but it is, yeah, we don't go on the clinical side, we go more on the administrative side. So, and let's go ahead and get started. We've already pushed the button that allows everybody to hear our conversations there. So hi, everybody. I know you probably heard us talking a little bit before we get started here, but let's get the official webinar going. My name is Mark Lynn. I'm a CPA from Chattanooga, Tennessee, and this webinar is going to be how to increase reimbursement levels and year-end incentives by integrating clinical pharmacy. You know, that's basically introducing quality into your rural health clinic. So we all know, you know, the government is pushing to get more and more quality indicators into all of healthcare by 2030. This is one way that you can take a step towards that. This webinar is being conducted by VitalSync, and I am with Healthcare Business Specialist, and it's sponsored by the Rural Health Clinic Information Exchange. Here at Healthcare Business Specialist, here is our team. As many of you probably heard, I made my announcement that I will be retired at the end of the year. So 12/31 will be my last day. So I will come off of here, and I think Danny's already hired somebody to take my place. So that wasn't, it didn't take long for her to replace me, which is easy to do. But here's the team at HBS. HBS will continue going and preparing cost reports and doing all the crazy stuff that we do, which is driving thousands and thousands of miles. I looked at my car yesterday, 256,000 miles on my car. So I'm gonna give you another car after this, because I won't be putting so many miles on it. But we do program evaluations. We help people become rural health clinics. Emergency preparedness. If you're in Tennessee, we do TennCare quarterly reporting. So that's the type of consulting work that we do at Healthcare Business Specialists. And if you want to suffer through a cost reporting webinar on Thursday, we will be having one. It's important because now that the caps have increased dramatically, the cost reports are much more important. And you have all these services like chronic care management, remote monitoring, those things that VitalSync do. And you can get additional reimbursement for, but you do have to keep up with those costs and report them correctly on the cost report. So we'll talk about things like that in Thursday's webinar. Here is our Facebook group that I'd mentioned earlier in talking. We have about 5,400 members in there. You're welcome to ask questions at any time. There's a lot of smart people in there, a lot of people smarter than me. That are very good about answering your questions. So if you have questions, please ask them there. Also tomorrow and I didn't put a slide on here, but tomorrow the NARHC is having virtual office hours at 1 p.m. So if you go to their website, get the Zoom link for that. Nathan Baugh, Sarah Holman, and I will be there. I'll answer your questions if you have questions about cost reporting as well from 1 till 2. Tomorrow. So that's always a good thing. That happens about every 2 weeks as well. And then if you want to go back and watch this webinar again, Or if you have people in your organization, we will post this to our YouTube channel. It is being recorded, so if you have an issue with that, you know, you can leave, but it is being recorded. And and it will go up on our YouTube channel probably either this afternoon or first thing tomorrow. It'll go on there. The disclaimer is everything is current as of today. The content that you're going to hear today is from VitalSync, and it's based upon their interpretations of current CMS guidance. As we all know, CMS guidance changes all the time, and things change. There's a lot of proposed regulations for 2025 that's going to affect chronic care management, remote monitoring, all of those things that VitalSync does. And talking, if you heard us talking before, they're mainly positive things that are going to be happening. We're going to do away with the dreaded GO 511 code and make the billing sort of more succinct and more accurate. So our information today is going to be updated as of today. If you do have questions, you're welcome to put them in the sidebar over here, and I will get those to Levance and Stacy. Or if you want to, at the end, we can open up your line and you can ask the questions to us through that. The slides are there. There's a handout over in the sidebar there, which has Levance's slides in there. I put them in the Facebook group, and I put them on our website at ruralhealthclinic.com. So you'll have access to them in 3 different places. In the past, we had offered certified rural health clinic professional credits. We are not doing that for this webinar, and we're not going to do it the one on Thursday. We just found it really was just too much of a hassle. We had to pay money to do it, and it was the only way you could get credits was you had to watch this thing live and answer the 4 poll questions. And poll questions, you know, a lot of people want to watch it later, and then they couldn't get credit, and then they get mad. So we just said, oh, good grief, it's just not worth the hassle. So sorry about that. And then our speakers today are Levance Northington with the CEO of VitalSync. He's been doing chronic care management for 20 years now. So Levance is a wealth of knowledge. He's done these webinars for us before, and it's been very informative. And then Stacy Ramirez, she's a clinical pharmacist with VitalSync, works at Oregon State. So, you know, has a wealth of experience as well. So I will get out of your way, and I'm going to turn it over. Let me see. I'm going to give Levance control, and he's going to do his presentation, and I will go on mute and get out of here and let you do your thing.
All right. Let's see, can you guys see my screen here?
Yes, we can.
All right, great. Well, hello, everyone. Thank you for attending. Greatly appreciate you guys taking the time out of your busy day today to listen a little bit about what we have to say about the value of clinical pharmacy as it pertains to integrating that into your practice today. For the agenda today, we just went through introductions. We'll talk a little bit about our advanced primary care services, how we integrate clinical pharmacy into that. And then Stacy will talk a little bit about a case study with her practice out in Oregon, and then we'll get into Q&A. So let's get into it. We just went over, our introductions. Myself, I've been an operator for about 3 decades now. Stacy, she is the pioneer of our clinical pharmacist model here. In addition to being a professor at Oregon State University, she maintains an active practice with 5 different locations where she's a primary care clinical pharmacist as well. The objectives of our engagement, of every engagement, goes above the triple aim of improving clinical outcomes for each patient, implementing population health management strategies, and reducing cost per capita. But we also want to help to reduce physician burnout, because we know you guys are working, or the physicians are working their behinds off, under the current environment, and to enhance socially marginalized populations. That includes senior citizens, minority ethnic groups, and then rural populations, with sub goals of identifying gaps in care, eliminating emergency room and hospital visits, and then again, improving quality. So how do we do that? Traditionally, primary care is focused around the physician group. And so we're looking to redefine what primary care is. We look at primary care similar to the old food group, the pyramid food group, where the physician group is just the foundational element of the primary care model, and we overlay that with a care manager who is the quarterback of the team. And what you see in green, that's our organization, that's our wraparound service that we provide. But the care manager is our quarterback. They provide chronic care management, remote patient monitoring, behavioral health integration, community health integration. We look at social determinants of health to identify things that aren't, things that aren't necessarily biologically relevant, but what's happening in their lives. We overlay that with a population health director, which is really an informatics position that looks at outliers. If, for instance, I've had kidney stones for the last 3 years, maybe there's something that I'm doing dietary wise that we can change. We have a dietitian on our staff as well. And then we overlay that with finally our clinical pharmacist, which is at the head of the pyramid for a reason. We believe that clinical pharmacists are kind of the silver bullet to the industry itself. We have, hundreds of thousands of professionally trained pharmacists that are not just the pharmacists that you probably envision of just writing prescriptions. These are clinical pharmacists that can, what we have them do is, first and foremost, provide medication reviews, but they also have the ability to evaluate and manage over 16 different disease states. They're not diagnosticians like a doctor, but once the ailment or disease or a situation has been diagnosed, they can manage and evaluate that. And then also they provide education to both the doctors as well as to the pharmacists. And so we talked about how we get started. The first thing that we do is medication checkup services, and that's what our pharmacists provide. And what that means is that we do it because most of your clients that are in Medicare are managed through therapeutics. It only makes sense to have a pharmacist as a part of that team, as a part of the clinical team. And so the first thing we do is provide that checkup service. What we'll do review. We look at everything that they are taking, whether it's over the counter or if it's prescribed. A lot of the herbal and dietary supplements are being taken by patients, so they're not necessarily reported to their providers. And so we take a look at that, record all medications that they have, because sometimes what we see in the EHR is not necessarily what they're taking. So we want to make sure that we can reconcile that. And then from there we start asking questions. We want to identify, are they taking medications that are not necessary, because there's a lot of excessive and then sometimes inappropriate medication use today when it comes to senior citizens. And are they taking medications that are that they need? They're not taking the medications that they need. Are the medications effective? Are they safe? And are they affordable? Those are the three things that we're looking for: effectiveness, safety, and affordability. And then we come up with an action plan moving forward on how to reduce some of those medications that they are taking. That falls into the care plan as well, and partnering with that quarterback care manager in providing the service. And then we document that for the doctors to see, and we provide monthly follow-up. This is something that we do on a monthly basis. The initial call that the pharmacist will have generally takes 25-30 minutes just to kind of get an understanding of where that patient is. And then from there, it's a monthly checkup just to make sure that everything is okay. They're taking the medications fine. They have any questions. The goal is really to educate these patients as well, so that they can become, have a deeper understanding of why they're taking medications and hopefully participate more so in their healthcare. Now, we talk about adherence, and why we're doing the medication checkup service is because there is a huge existence of non-adherence here in the U.S. Of every 100 prescriptions that are provided, less than 30% of those are taken properly. And that causes a lot of financial burden on the system itself. We look at about 400 $400 billion are attributed to non-adherence and DDIs. And so by integrating clinical pharmacy and just simply having that medication checkup service, we can knock out a great deal, a great portion of that $400 billion in expenditures. And so we talked about medication checkup services being the first service that we provide, but that's just to get you guys familiar with us. Once we provide the medication checkup service and it's something that you feel that we're comfortable with, and again, let me go back. During the medication checkup service, our pharmacists, who are all licensed, they do not make any changes to any of the medications. I want to reiterate this. They make no changes. All they are doing is giving recommendations to the doctors. And so we do the medication review. We provide the documentation because there's a form that we fill out, that the pharmacists fill out and provide to the doctors on a monthly basis. And it's up to the doctors to make the changes themselves. They may say, no, we don't want to make these changes, or they may not want to make or they may want to make the changes. But more often than not, probably 75 to 80% of the time when we do our initial checkup, there are recommendations that our pharmacists are making. But once that's phase one, and once the doctors become comfortable with us, the next phase is to enter a collaborative practice agreement. So we take our service a step further, as opposed to just doing the checkup service. As we mentioned, we have the ability to manage and evaluate and manage over 16 different disease states. And so we will actually start monitoring a patient's disease state every month. A doctor may have a patient that they see 1 to 2 times a year if they have RA or diabetes or something of that nature, whereas our pharmacy group, they actually will meet with that patient every single month to make sure that the medications that they're taking are working properly, get real-time feedback from that patient so that we don't wait every 6 months to make a change in their therapeutics. We do that on a monthly basis, and they have the phone number to call to their pharmacist if something is going wrong. And then lastly, if after we do collaborative practice agreement and that's going good, the last thing we do is actually integrate our clinical pharmacists into the clinic itself. And Stacy will talk a little bit more about that, because that's the end game for the entire healthcare system, is to have clinical pharmacists completely integrated with the clinical practice, because there's a great deal of value there. As I mentioned in phase one and phase two are remote. We do those things remotely. Phase three, again, we're actually putting a pharmacist in the practice, and they are a part of your daily workflow. Rather than having the on the phone communication with the patient, they can have those patients in the office. They do all the notations, things of that nature as well. And with your providers, at the end of every provider visit, they will send in the pharmacist to ask them if they have any questions, to educate those patients again, so that they can start taking place in their own health. This type of service has a profound and direct impact on HEDIS and star ratings. As Stacy will talk more later, the star ratings have a heavy component on medication efficacy and things of that nature. We do everything from pain assessment to controlling blood pressure, medication adherence in cholesterol, diabetes, hypertension, statins, and so on. So there's a huge value to both the patient and to the clinic itself as it pertains to meeting your star ratings and those incentive bonuses. And then, there's evidence beyond what I'm telling you here, beyond what we've done ourselves and what we've seen ourselves and how we've impacted. The Surgeon General did a study and showed that for every dollar that they spent during that study, they saved $10. And that's fairly significant. Every dollar spent, they've saved $10. And that's why CMS is willing to reimburse for these services right now. And then more recently, the VA has actually done a study themselves, and they've identified and documented for every dollar that they spent, they've been able to save $28. And the VA probably has the most expansive, not probably, but they do have the most expansive use of clinical pharmacists in their traditional care, primary care practices around the country. And I think, Mark, from here, we can ask a quick question, that first question that we had.
Yeah, I just launched the poll. So if you would click on, select one of the 4 areas here. In what area do you think clinical pharmacy can benefit your clinic most? Part D, quality attainment, identification of gaps in care, improving patient outcomes, or access to increased services for patients. If you'll answer that, that would be great. We're collecting answers now. 37% have voted so far. So let's get a few more folks in. And 44, 48, 52% have voted. Okay, well, looks like 57% of the people have voted for improving patient outcomes. 20% have said access to increased services to patients. 20% have said identification of gaps in care, and 7% have said Part D, quality attainment. So 53% for improving patient outcomes is the answer to that, Levance.
Okay,
and I'll close the poll.
Great. Thank you. And so Stacey will talk a little bit more about access to services. So additional benefits that we have is access to real-time health data as well, evidence-based assessments and care plans, which leads into improving clinical outcomes because of our team-based approach when we are working with your patients, and alignment with your payer policies. One of the things that are our biggest and largest goal is improving clinical outcomes of every patient. I think the fact that we have our operation or our protocol is a patient-centered medical home type protocol where everything is focused on the patient itself. All of our services are coordinated. It's team-based and it's evidence-based. And so by utilizing our services, which is a wraparound service, you're going to, if you're looking at getting qualified or certified as a patient-centered medical home, just by utilizing our services, you're 80% of the way there by utilizing our services there. So we are kind of aligned with what you guys are trying to achieve and what you expect out of a relationship of this nature. We've talked about the benefits of clinical pharmacy and care management to the payer, benefits to the member themselves. And the most important thing really after clinical outcomes is improved member experience. And once when a patient knows that they have the ability to communicate with a pharmacist on a monthly basis, if need be, whenever they want, they can call that pharmacist. Their experience goes up significantly because they have a greater engagement from the team, and we give them the tools and the skill set to self-manage themselves. And so now I'm going to hand it over to Stacey. Stacey's going to talk a little bit more about the case study that we kind of founded, the founding principles of implementing clinical pharmacy into rural healthcare. And so I will hand it over to you, Stacey, from here.
Great, thanks, Levant. All right, so I am going to talk today about the practice side and the place that I've been practicing actually for the last 18 years prior to meeting up with Levance and really trying, really seeing the benefit of taking what we've learned in my current practice and being able to apply and offer that to a larger group of people. So earlier in the presentation, Levance talked to you about kind of the phases of integrating clinical pharmacists that we're looking at. So the first phase is med reviews. As I talk about what our practice looks like, we do med reviews on every patient that we see, regardless of what we're seeing them for. So that's already built into the more advanced practice that we do. But I'm really going to focus more on the second phase and the third phase as to kind of where we see this going. But just know that the med review process, which is, again, reviewing medications, reconciling and making sure the medication lists are updated, identifying any medication-related problems, and then providing both the provider and the patient with recommendations on how to do that. That will happen regardless. That's sort of the baseline of everything that we do. And then the additional services can be layered on top of that. But again, that's really where I'm going to kind of focus today because the med reviews are relatively straightforward, pretty easy to integrate into a practice, and definitely of value. But where we see the real value down the road is in this true integration of clinical pharmacists onto primary care teams. So my practice site currently community health centers of Benton and Lynn counties. We're in FQHC. We have 5 access points or 5 clinic locations, 2 of which are school-based health centers, and then the other 3 are more traditional community health centers. In our 5 clinics, we manage about, we have about a panel of around 10,000 patients. So we're not a huge clinic, but definitely suitable for the area that we're serving. And that, with our traditional primary care providers, that can be around 15,000 in annual visits if we anticipate that many of our patients are seen 1 to 2 times a year. And then in our model, we have been working for the entire time that I've been there, so the last 18 years, really developing our primary care teams. But pharmacists were the first non-PCP integration into our model, and then we've added additional provider types or additional service lines from there, such as behavioral health, community health workers, care coordinators, and so on. So within our clinic locations, we have 4 FTE of primary care pharmacists and 7 care teams. And so each of our smaller clinics are their own care team, and then our larger clinic actually has 3 care teams within that facility. So our 4 FTEs support all 7 of those clinics. Obviously, in some of our smaller sites, there may not be a pharmacist there 5 days a week. There may only be a pharmacist there 2 days a week, and then there's someplace else those other days. But what that's really allowed us to do is, again, truly integrate these services into the delivery of primary care. And for us, LaVance mentioned that there are 16 disease states that pharmacists can treat. That number actually potentially is much higher. That's just what we do in our particular practice. So in our practice, our pharmacists enter into an agreement with our providers that allow us to comprehensively manage those 16 disease states. And when I say comprehensively manage, we use the pharmacist patient care process, which is a system that involves collecting information, coming up with the most reasonable approach to solving a problem, and then monitoring and follow up. So for us, that means that we actually take over the management of the condition. So again, we're proposing this to start, but this really is where in our clinics we've seen the most benefit. So I, as a primary care pharmacist, can start, stop, adjust meds. I order lab tests. I make referrals. I can order imaging if it's appropriate. We do basic assessments, so collecting vitals, doing some, not anything. We're not advanced diagnosticians. That is not our role. And actually, pharmacists, that's a hard stop for us. We do not diagnose. So someone else diagnoses and then sends them to us for management. But that ability to kind of comprehensively take over whatever that chronic disease management is definitely frees up our provider time to focus on more acute visits, more acute problems. And we found that, again, provides better outcomes, especially in those diseases that we're looking at. As an example, excuse me, I'm getting over the tail end of, I call it the airplane cough. As an example, for us, we manage what I would say are traditional pharmacist managed disease states like diabetes, hypertension, hyperlipidemia. But we really wanted to be able to mirror what we actually see in primary care. And while that's a decent chunk of the patients that we see, we also do some mental health, so depression and anxiety. We do PrEP and PEP, hepatitis C management, and a variety of other things. We also have, which is one of the big selling points for our providers, we also have the ability to refill meds. So if a provider's out of the office, we can manage their in-basket and approve or deny refills. And so that has been a big help with our provider group. And again, I think that studies have shown, and we also know anecdotally that that our providers really appreciate the service and the ability to hand off what oftentimes ends up being very time-consuming visits to our clinical pharmacists. So for us, we figure we manage about 700 patients, and that seems like a smallish percentage, but again, that's 700 patients that tend to need a lot of care. So I joke, like, I have not gotten a referral of a diabetic patient with an A1C at goal and only on metformin. Those are not the patients that we see. We see the patients whose A1C is greater than 14, they're on 4 meds, they're not doing well. And so again, those are the people who really require much more intensive management, and that's really where we come in. Levance mentioned that a huge chunk of the star ratings actually are influenced by medications, and that's appropriate prescribing and adherence. Studies have shown that about 45% of your star rating actually is directly tied to appropriate prescribing and adherence, and that's really where your pharmacists come in, because that's where our training is. And as an example, in our clinic location, we have, so we're in Oregon, so I know that if you're not in Oregon, our reimbursement for our Medicaid and our dual eligibles is a very different process than it is in any other state. But for us, we have incentive dollars that are tied to particular quality metrics that we pick. And so consistently, we pick quality metrics. At least 3 of the 5 that we focus on are areas where pharmacists will be directly involved, because we know that that, again, allows us to meet those quality metrics. We pick comprehensive diabetes management, hypertension control, and depression monitoring and management are the ones that are consistently a part of our quality metrics. And again, in those areas where pharmacists are involved, we consistently meet or exceed our quality metrics, which not only improves patient outcomes, but again, is tied directly to better reimbursement overall for our clinics. Go ahead and go to the next slide, Levance. All right, and I already kind of said this. So yes, we consistently meet or exceed the quality metrics. We definitely have improved patient satisfaction scores. And again, we see this within our clinic practice, but there's also tons of research out there that show that primary care practices that have a clinical pharmacist embedded definitely have better satisfaction scores. And then if you look at provider satisfaction, those scores dramatically improve when you've got the support of a clinical pharmacist. The dollars definitely are important. So it's a little difficult to pull these numbers out. So this is my best estimate. The reason for that is that we track everything based on the team. And so it's hard for me to pull out exactly like what my impact on my team was. But the numbers that we've used in our practice is about an additional $250,000 in incentive payments that are in those quality areas where we have pharmacists involved. And on average, our pharmacists we see about 5,000 patients a year between the 4 of us. And if we average that out, again, I said $50. It really depends on the payer. In Oregon, we have a lot of performance-based or alternative payment methodologies, which makes identifying an actual reimbursement a little bit more challenging, but this is probably pretty close. So again, our visits are adding an additional $250,000 plus the improvement in outcomes, the reduction in provider burden that we see with our visits. And so our clinics, I can tell you, again, we started this 18 years ago. We keep adding. So I just hired my most recent resident to stay on with us because there seems to be more and more demand for the services that we are providing. Okay, I think next slide. I think that was it for my portion.
Yep, that was it. Thank you very much, Stacy. Mark, if you can add this last one here.
Okay. Do you want me to? I just launched the last poll, and the poll question is: do you have performance-based incentive structures with your payers? The answer: you have 2 choices: yes or no. And wow, looks like a lot of you guys have this already set up. I'm impressed. So far, we've got 50% of you have already voted, and 86% of you say yes, you already have these performance-based incentives set up. So that's great. Okay, I think I'll close out the poll then. 88%. Look at you guys. That's very good.
Yeah,
So
that is great. And one of the things to note for you guys is that a part of our service is that we do partner with you to understand exactly what those incentives are, to understand from each payer what your incentives are on a monthly basis, because you guys are probably meeting with them monthly, where you're at in your attainment and how our services can exactly impact those numbers, so that we can help you to be as to achieve as much of those metrics as we can, and including pharmacy is going to do get you guys a great deal closer to achieving that. So that's just a part of our service. So last thing, what we want to talk about is reimbursement and fees. One thing that I didn't mention is that all of the services that we are talking about are 100% free. If I can say, not free, but no out-of-pocket cost for you guys. CMS will reimburse for all of our services. We provide all of the service, all of the manpower. CMS will reimburse. This is an incident to or an E&M type service where we are working as an extension to your organization. The reimbursement schedule for the medication reviews is about $96. We charge $60, so it's about a $36 delta just for the medication review service. And we talk about our care management services where we're doing care management, remote patient monitoring, behavioral health, or community health integration. Those are different billing. We can bill differently for G0511 if we're doing 9999 codes. Each one of those that are mentioned below have a different 99 code. So we can bill individually for each one of those, and you can look at a $36 delta per month for each one of those. So if we're doing chronic care management, remote patient monitoring, community health and behavioral health, plus your medication reviews, look at $36 times each one of those. So the reimbursement levels can get fairly significant, and there's no money out of pocket. If there are devices that are sent out or anything of that nature, we are the ones that pay for that upfront, and we're reimbursed by CMS. So again, it is really a win-win situation for everyone involved. So that's kind of the end of the formal presentation. If there are any questions, we would like to answer some of those questions. Feel free to give me you can email us later if you want to set up a time where we can get on a Zoom call to dive a little bit deeper into your specific needs and organization and how we can implement clinical pharmacy into your practice. Again, if you are managing chronic conditions, every single Medicare patient should have a medication review. That is our moonshot, is to provide medication reviews for every Medicare patient in the country. Every Medicare patient in the country will be paired with a pharmacist so that we can mitigate some of the issues that we have with non-adherence, and mitigating those non-adherence issues will improve clinical outcomes significantly. So with that, let's open up the questions.
okay, you can ask your questions over in the question box, and we have one so far. And or if you want to open up your line, there's not many of us here, so feel free to just click over here, and I'll be glad to open up your line for you. Just raise your hand is what you do. So here is the question: is a pharmacist a QHP? I'm not sure what QHP stands for. I'll go ahead and read the question, and y'all can answer that. Is a pharmacist a QHP for RHC to be reimbursed for having a face-to-face visit with the patient? Okay. A pharmacist would not, okay, I understand the question now. A pharmacist would not qualify for a face-to-face visit where you're gonna get the all-inclusive rate. That's the question. Levance, Stacy, I'll let y'all answer that question. Is that the way you would answer it?
Yeah, well, to start, if we're doing, again, medication reviews, basic medication reviews, we won't do face-to-face. But if we are embedded into the system, we will be not involved in the all-inclusive. They're actually paying us above and beyond. And it's the 99 codes. Again, CMS reimburses us as an incident too for every 20 minutes of communication. So if we are inside your inside your clinic, we will be able to reimburse for every 20 minutes that patient that our pharmacist is there. And again, there's no cost to you. We incur the initial cost. That pharmacist works for us. We're just providing a service to you. So we do get reimbursed for face-to-face visits when the pharmacist is integrated into your system.
Okay, and I'm looking, I'm not seeing any other questions. I know from personal experience, my daughter's doing her rotations as a PA, and the first rotation she did, went to a rural health clinic that actually had a pharmacist on site, had some other services, and she was just thought about how amazing it was to have that pharmacist there to help these patients adhere. I know as going on Medicare, this is the package of medicine that I have to take every single day. So believe me, having somebody to help manage this would be great. So how do I sign up for your services? Because I need them. But
well, we will talk after this. Is
best
something
way for our people to sign up with you is your information is here and get a hold of you.
Yes, that is definitely the best way here, is to get a hold of us, and we have to go through your primary care, Mark, for you. But yes, work with each one of you guys to implement this program. I see a question here about the MTM program in Tennessee with Medicaid and Medicare. It's where pharmacies are managing medications prescribed for the patients. It is an additional contract for these providers. Yes, those pharmacies are signing the collaborative practice agreements. That's the CPA. We said that is phase number 2, which is a additional agreement that you would have to sign. We provide those very similar type of services from that perspective. But we're not just managing the therapeutics, we're also managing the various disease states. And a lot of these times when you have basic MTM services from a local pharmacy, they are just doing the medication reviews. Again, we go beyond just medication reviews. We look at our pharmacists as primary care clinical pharmacists.
Okay, yeah. And I found a couple more questions on here. It says here, I'm not sure if this is what you just answered, but are you familiar with MTM, Medical Treatment Management Program in Tennessee for Medicaid and Medicare Advantage members? It is where pharmacies are in FQHCs and RHCs and are managing medications prescribed for their patients at those clinics. It is an additional contract for these providers. That's from Amber.
Yep, and that was what I was referring to when I was answering that question.
Okay, gotcha. Okay, gotcha.
Yeah, that is the collaborative practice agreement that they are signing, which is our phase 2. And they typically, when you have a pharmacy, again, they are just doing the medication, medication reviews. Typically, they're not typically primary care clinical pharmacists that are managing diseases. In some cases they are, but not always. And so you have to look at that. Again, you've heard of the extension that we go through as far as managing disease states as well, if you're looking at signing a collaborative agreement. And then we take it the next phase and we put a pharmacist in your clinic, whereas a lot of these pharmacies may not be doing that. And then let's go to the next question.
Okay, next question is, are the 20 minutes under the CCM billing, or what is the $50 that Stacy mentioned they bill for?
So those are two different things. What Stacy's talking about in her practice is not 100% apples to apples in how they're billing, because they are billing in an all-inclusive rate there. She is attaining the $50 roughly based on the various carriers. One bill may be $150, another one $25, another $75. She's just using 50 as a rough estimate to account for the dollars that she's billing. The 20 minutes in the service that we're talking about providing is under what CMS is providing via CCM, RPM, and the medication management. So CCM and RPM have a 20-minute. You have to have 20 minutes, but with medication therapy, you don't have to have. It's not a time allotment that's necessary there.
And that 20 minutes is going away next year, is the way I understand it. So because it's going to be based upon code. So the GO 511 goes away, the 20-minute rule goes away, and you just follow the E&M code. What's required for that?
That is
Okay,
true.
looks like we have one last question here. Do you also help with medication adherence for those on MAT medications to help them manage addiction? Because yeah, there's where we are in Tennessee and Kentucky. There, oh my goodness, that is a huge problem here. So we need that.
Right. So it certainly is with adherence. That's certainly something that could be part of the process. It's not something, at least in my practice, actually we're working on implementing it right now. We just applied for a grant to allow us to expand and have our clinical pharmacists be involved with our MAP program. But certainly any type of adherence counseling, and sometimes it is just problem solving with the patient, right? Like, why are they not taking their medications? Is it something as simple as setting an alarm on their phone to help them remember? Or explaining the importance and what happens if you don't take your medication regularly. With MAT, sometimes it's, I don't know about you guys, but a lot of our patients who are on MAT are having, the Suboxone strips taste terrible. And so figuring out ways to kind of help them manage that, making sure that they're getting regular dental care, because we know that most of the sublingual MAP products are now impacting oral health. And so all of those things certainly could be part of what we would consider a regular medication review. And so that would be, those type of things would be what we would send to a patient in their action plan. So setting reminders on phones, putting your medication by your toothbrush or your coffee pot so that you see it at a predictable time every day and can remember to take your meds. Finding pharmacies that have specialty adherence packaging, things like that. Those are all types of things that our pharmacists can assist with. So it wouldn't just be for MAP, but certainly would roll right into that.
Yeah, Olivia from the South Carolina Office of Rural Health, which is a wonderful place there, home of Marshall Mars, Graham Adams, and Shannon Chambers, which we all known all them for years and years, says that they've started a chronic care management at South Carolina Office of Rural Health in 2020, and it's grown the program to now have 2 clinical staff assisting. And Olivia says they would love to help continue to spread the word of adding pharmacists into practices, because I think that's important. So any comments on that before I move down to the next question? Just keep up the great work.
Spread the word. That's what we say.
Spread the word. Yes, any way possible.
I wonder, she says chronic care management, does that include, is she doing that with clinical pharmacists? I wonder.
I don't know. I guess, Olivia, if you want to open up your line, we'd be glad to talk to you.
Yep,
Or you can just answer on here. Oh, she is the clinical pharmacist. Okay.
Great.
Okay.
Perfect. Yeah.
All right, and Amber has a follow-up question too. Yes, my team manages the MAP program in Tennessee, and we work with medical versus behavioral health providers. So that's what Amber's doing. So sounds like you guys are doing great things already in some of these places. But if you don't have something like this set up, then you need to talk to Levance and get the program started, because it will be beneficial. I know from being a chronic heart failure patient for now 7 years, managing your medications is hard. I am the best patient ever, but probably not everybody is the best patient ever like me. That's what my cardiologist always says. Right? If everybody was like you, this would be an easy job. So any other, let me see. Oh, Brittany came in with a question here. We do CCM with the pharmacist on the team. Okay, so
great to hear.
That is great. So it sounds like we're preaching to the choir today, because everybody seems to be really on board. So okay.
Yeah.
All right, well, we're gonna close it out now. Thank you, Levance. Thank you, Stacy. We appreciate everybody. We appreciate everybody that came today. Like I said, we are going to get this thing recorded. We will send out the slides and a follow up with everybody, probably be tomorrow before I get around to it. So thanks, everybody. We appreciate it. We're gonna turn it off now. All right, thank you.
Thank you.
Bye, everybody.
Bye-bye.
Bye-bye.